along the longitudinal axis of the clot, and TPA is infused. You know the protocols: 1 milligrams, 1 cc, along with 3 cc's of saline into the tissue, into the hematoma every 8 hours for about 72 to 96 hours. And then you do daily head CT over the next few days to demonstrate a progressive reduction in hematoma size. And again, it was a safety clinical trial. There was no difference as far as safety issues between the MIS group and medical management group, although there was a 3-fold increase in asymptomatic hemorrhage rate in the MIS group. The second category is primary mechanical. And again, there's multiple techniques out there, but the most common one would be putting in a sheath along the long axis of the hematoma using neuronavigation systems, one of them, and then basically putting the sheath at the distal third of the clot, whether you're going through the front or through the back, distal third of the clot. And through the sheath you advance your endoscope, through the endoscope you advance your suction system, whichever one you like. And then basically the idea is to suction your way back as you keep pulling the sheath, as someone, your tech or another surgeon, another helper, will keep pulling the sheath back as you continue to suction your way back. And your goal would be try to achieve the CT scan next to the first one. And I mean, the most good example is the one, the ISIS trial, which was published in 2017. And again, it was also a safety trial. So really in this part of the world, there is no good randomized clinical trial that showed significant benefit, even with MIS. Most of the data comes from Asia, from China and Korea, where they have 40% of their strokes are bleeds. Great clinical trials and big ones like this with 300, 400 patients showing significantly improved outcomes as far as dependency at 3 months is concerned. There's really a huge data out there, and it suffices to show you this meta-analysis because it just got published about 4 weeks ago by the group at Mount Sinai. They looked at 15 high-quality randomized clinical trials dating back since 1989, over 2,000 patients, basically probably the best one so far because the last one was in 2012. This meta-analysis showed us that the subgroup of techniques as well as time to treatment, they went into those details, and the first panel shows you that MIS compared to other treatments, which includes open craniotomy or conservative management, did significantly better. And the second panel, B, shows you that MIS with against craniotomy alone, which is any kind of mechanical removal. The third category is panel C, shows you endoscopic evacuation only, and the fourth panel is stereotactic catheter placement in thrombolysis. So all these subgroups of techniques have actually been shown to be superior to medical management or open craniotomy. They also looked at in this meta-analysis that treatment from the ictus, whether patients are evacuated within 24 hours or if they have been evacuated within 72 hours, they did still significantly better with very, very low p-values, as you can see there. Still though, the evidence is still class 2B, level of evidence B. It's uncertain. We need more clinical trials. That's why really the focus over the last several years has been using the newer generation devices that are more effective and building clinical trials around these new devices. The most famous ones, or the 2 common ones that are being used in North America are the Artemis Neuro Evacuation System by Penumbra, and the other one is a NICO device from the NICO corporations. I'm sure you had a chance to look at them in the displays in the back. But this is the Artemis system from Penumbra, which shows you that it has a wand, and inside there is a shaft, a rotating shaft with a blade at the tip of the shaft that technically breaks into the clot and then makes the clot to be suctioned easily. This is a NICO system. On the left-hand side, it shows you the obturator in the sheath that allows you to advance stereotactically into the clot. And on the right side, the handpiece that has a side port that also cuts into the clot and makes suctioning of the clot much easier. So quickly, 2 clinical trials are built around these 2 new devices, as I said. Enrich is a clinical trial which uses NICO system, hematoma evacuation within 24 hours. They're looking at 10% improvement in functional outcome compared to conservative management, 30 to 80 cc of hematoma. They started enrolling about December 2016, and a dozen centers are already doing it, and they're predicting to complete the clinical trial by December 2019. The next one is MIND. This one is built around using the Artemis Neuro Evacuation System from Penumbra. Pretty similar inclusion exclusion criteria. However, this MIND clinical trial is enrolling patients within 72 hours of the ICTAS. It just started, about only 5 centers are out there enrolling patients. The other one is INVEST clinical trial. It's a single-arm feasibility study started at Mount Sinai by Jay Marco and his group, and they basically want to see the rate of enrollment and follow-up of this group of patients, again within 72 hours of the ICTAS, and they also have a registry. Whoever doesn't qualify for the INVEST clinical trial goes into the INVEST registry. So I just wanted to show you our early experience as interventional neurologists doing MIS. We've been interested in it for a while. And finally, as we saw more and more this device are coming to the market, we wanted to partner with our local neurosurgical colleagues, and we told them the idea, they bought into it, and we convinced the administration to buy the equipment for us, and we started doing it. So I just wanted to show you quickly 2 cases to illustrate the process. First case is a 66-year-old female, hypertensive, diabetic, and she developed acute left hemiplegia. Her husband gave her aspirin, thinking that it was a heart attack. The nice guy, but about 112 cc of hematoma in the right frontal region, about 6 millimeters midline shift. As you can see, the top panel is before we evacuated the hematoma, and the bottom panel is after evacuation. And I understand that this is our very first case, and we have the device companies in the room helping us out with the device and all that stuff. And to our surprise, and undeservedly, this is a great result. We're very happy. We felt like we removed more than 90% of the hematoma. Just to show you sort of can this video run? So, sort of looking in front of me to the left is a neuronavigation system, and to the right I'm looking directly into the endoscope where I'm looking at the clot. As you can see, I'm sort of advancing the suction system, or get to the clot and then continue suctioning. You can just so you see the endoscopic screen on the right side. On the left side is a neuronavigation system. You see the dark clot, the hematoma, just popping up as you continue to suction. This shows you again, to my left is my favorite neurosurgeon, Dr. Betancourt, who is sitting there and kind of helping me out. And so again, straight ahead is a neuronavigation system 1 screen. It could be the Stealth, the Medtronic system, or any system that you use. And to your right will be your endoscopic screen. Slightly bigger craniotomy, as you can, burr hole, as you can see. I don't know, some of you, if you do burr holes, tends to be smaller, but these burr holes are about 1 to 1.2 centimeters wide. And as you can see, the sheath is kind of peeled out. As you, like I said earlier, as you keep coming back up, the sheath will be peeled out, and then finally it will be removed as you remove the endoscope. But that's kind of how it looks like. So not very surprisingly, she did extremely well. 6/17 was the day she presented to us. You could do this procedure within 72 hours, as you know, but the perfect timing, probably the recommended timing, is between 24 to 36 hours. 6/18 is when we did the evacuation. 6/19, she was extubated. 6/22, 5 days later, she was sitting on a chair. Show you the pictures, and by 6/25, she was advancing diet, giving us high five there. And obviously, she's weak on the left side. She could barely move her hands with just a little withdrawal, and her left face was droopy. And her discharge exam was about the same. However, 3 months follow-up, she was MRS3, she was able to walk, she was able to have anti-gravity on the left arm. She had difficulty moving her fingers, but she did extremely well. This is her 2 months follow-up, non-contrast ATT. Quickly, the second case, a 50-year-old male, hypertensive, non-compliant, drug abuser, again developed left side weakness, large right frontal basal ganglia bleed with some intraventricular extension, about 8 millimeter midline shift to the left. As you can see, the top panel is before evacuation, the bottom panel is after evacuation. Immediately, if you look down to the CT, the right lateral ventricle, which was completely squashed, has sprung back up. In fact, we didn't even need to put the ventriculostomy catheter. We felt like maybe 70% of the clot is out. So he did so well. Actually, he's still in-house. Day 10, I saw him the day before I flew in, extubated, alert, and talking, effectively, but he's weak on the left side. He only has a visual response, and I hope to see him in a follow-up. So very quickly, I'm running out of time. My impression, us doing MIS. If you deal with these patients on a daily basis in your neuroperculture unit, and if you're interested in getting involved in doing MIS, I think you need to start routinely doing ventriculostomy catheter placements, whether it's by the bedside or in the operating room, whichever is convenient. And then as far as training, I would suggest the cadaveric course that is organized either through the device companies, or there are some sites in the country. I went to Memphis with Adam Arthur and Dr. Kendler from Mount Sinai. They were giving this cadaveric course. It's very good. It helps you sort of get the hang of how to hold on to an endoscope and advance the suction system through it. And sort of the eye-hand coordination is not going to be anything new for you. We're all used to that eye-hand coordination, but it would be very helpful. And then you come back and with a good track record of putting EVDs by the bedside or in the OR, and your certificate of training on a cadaver, I think the hospital will give you a privilege on conditions, which would be proctored 5 to 10 cases of MIS with a neurosurgeon, and then after that you will be able to do it by yourself. And really, ultimately, I think we need to be involved. This is really a good time to get involved. Like I said, InReach has only about a dozen sites so far. They're planning to enroll 300 patients. Mind has only 5 sites, and they're just starting to enroll. We don't really have a good evidence. This is an orphan disease. Nobody really cares for it, right? ICH, there's nothing neurosurgical to be done for a large basal ganglia bleed, and neurologist says, I don't know anything, so that's why it's called an orphan disease. Nobody wants to own ICH. And so I think this is a good time to be part of evidence first, and I think then once it's proven to help our patients, then we can talk about the rest. I think personally the future is bright. I think the benefit is beyond primary ICH. We can treat our own complications with it. And again, we even talk to these device companies, to the cath lab owners, maybe fitting DynaCTs, high resolution fetus into the cath lab system, and neuronavigation system inside the cath lab system, so that we don't have to be watching into multiple screens. And I think that's the future. So acknowledgement to my most favorite neurosurgeon who bought into my idea in the beginning and helped us, Dr. Hassan and myself, to start this program at our site. He's a phenomenal guy, big heart. You need people like him. Thank you very much.
Thanks, Dr.